Well, hello, everyone, and welcome to another episode of Oracle Health Inside Access. I'm Shanna Adamic, and it is a pleasure to be your host of this episode today. Now, we are just a couple of months away from Oracle Health Summit in Nashville, and I am thrilled that we are going to be discussing a critical topic today, one that we'll also be discussing at the summit in Nashville. Now, before we get to that, I want to touch on a housekeeping topic, and that is we want to engage with you. So please use the chat feature of your LinkedIn live stream. Make comments, ask questions, put in your thoughts, whatever it may be. We have team members standing by and ready to engage with you. And thank you so much for engaging with us. And it is a pleasure now to bring on Sam Lambson, who is the Vice President of Interoperability at Oracle. And he's going to share more on how we are connecting healthcare through data. Sam, thank you so much for joining us today.
Thanks, Sean. Happy to be here.
Well, Sam, in just a few minutes, I'm actually going to turn it over to you and your team to lead, a panel discussion talking more about interoperability. And you're also going to have a live demo that shows us the latest product innovation in the space, which is seamless exchange. But before shifting gears to that, I want to talk about all the activity in the space and what's going on around the world. Now, I just saw you in Australia, so it's great to see you again and have a moment to talk and connect in this way. But you have been to a lot of different places, involved in a lot of different things. And so I'm going to actually read off this list of everything that you've spent time doing in the last few weeks and months and over the span of this year. You've been involved in the Canada Health Infoway Industry Collaborative and participated in Share Care Records Summit hosted by the National Health Services in the UK. In the US, you are on the board of Commonwealth Health Alliance and represent Oracle in the TEFCA, did I say that right? TEFCA
Yeah, that's right.
Transitional Council. And so I'm curious, all of that's a big list and a lot going on, all of that across these activities. Are there any trends that you're seeing from around the world that can help us in today's discussion?
Yeah, boy, Shauna, it has been a whirlwind of visits. As I visited these various regions, I've experienced varying levels of maturity, but we're all working towards the same ends, which is trying to get from having a digitized record to actually improving healthcare for both providers and patients and the experience they're having with the data that's been recorded. What you see is a pattern that has kind of repeated itself across the globe of trying to enable interoperability for the various jurisdictions. The first step to that pattern is creating sharing networks, the ability to share the information. The second is to establish common standards and data sets that give everyone a common set of information that does get shared. And then finally, and the most important thing really is how do we make the workflows that patients and providers use every day meaningfully impacted by all the data that's been made available. And in my travels, I've talked a lot about that first one, which is creating a common data sharing framework or networks at the national and regional level. Lots of discussion about both the technology and standards that we use, as well as the governance and how do we create and engender trust among those entities that are sharing information, those participants in these interoperability networks. For example, in Canada, we created a charter recently issued by a group of suppliers in conjunction with that region, where we collaborated in creating a consistent pan-Canadian approach to interoperability, very similar to what we've tried to do in America with the Commonwealth Health Alliance. In the UK, I attended, I think this is the second time they've done it, but a shared care record summit. And afterward visited with a number of our clients that use our HIE technology as the backbone of their share care records. And I learned a lot about how they're growing their network, broadening the usefulness of the information, adding general practitioners or primary care clinicians to hospitals, to community care. It's really an impressive undertaking in that area. Finally, in the US, we've been really hard at work launching the Trusted Exchange Framework and Common Agreement, which is what that TEFCA acronym was all about. We'll talk more about that today with the panel, but that has been a very large undertaking for many years in the US and really represents where we're going. The common thread, though, across all of these regions, for me at least, is that we are actively creating networks that connect as many participants as possible to share that clinical information securely and in a trusted way to support patient care.
That's incredible. I mean, it sounds like incredible progress, and you're clearly passionate about it, as you should be. And I am too. I mean, how can you not be? This is an exciting moment in time to be leading this change and this transformation in healthcare, to have this be a moment where it really empowers that physician and creates this seamless experience for the patient. So very exciting stuff. And I've heard you speak. Can't wait to hear you speak again. And I know we're going to run into each other in the summit in just a few months. But for right now, I'm actually going to pass it off to you and your team to continue the discussion and share with us a live demo.
Thanks so much, Shanna. I've really enjoyed catching up with you, and I look forward to diving in at the conference as well. I'd like to introduce and welcome Hans Buitendijk and Siva Edupuganti to the discussion. Hans is the Senior Director of Interoperability Strategy, and Siva is our Senior Director of Interoperability Product Management. Thank you both for joining us today.
You're welcome.
Happy to be here.
Hans, you've been a longtime leader in interoperability going back several decades and are currently actively involved in several key standards bodies and industry trade groups and that are critical to how the interoperability is implemented consistently within the industry. Can you tell us how interoperability has evolved during your time?
Sure, happy to. And actually, that's going to go back a couple of decades and back into the 80s when I started. And in many ways, I was already jumping into interoperability at that time. So it has been going on for a very long time. At the time, I worked for Shared Medical. That became part of Cerner. That's now part of Oracle Health. But from that time forward, we have been working on connecting applications, connecting departmental systems internally, external laboratories, et cetera, et cetera. So over the years, we have done connectivity in many different ways. And we also were actually a part of the first implementations of HL7 version 2 to message with other laboratories that has now evolved to HIEs, health information networks, et cetera, et cetera. So it has been part of the work for a long, long time. And for anybody that believes that it's not interoperability unless it's RESTful, or it's not interoperability because it's not FHIR, or it's not interoperability until you do national level networks in the early 2000s with intra-vendor, cross-vendor, every side. No, we have been at it for much longer than that. And in a way, Oracle Health, or Oracle, has been at it for even longer than that, with establishing the core fundamental building blocks, SQL, to be able to access data, and that's now used in a variety of different ways to share data as well. So it has been part of health IT fabric for a long period of time.
Thanks, Hans. I wonder if you might follow up and really talk a little bit more about what's going on today in the interoperability environment.
Sure. And today, the main purpose of what we're after is still the same as what we've always had, is that getting the right data to be shared with the right person, right time, allow the care team and the patient to make the best possible health and care decisions. And if you don't take that in today's world, what does that mean? We're really looking at across the globe, actually, at national level exchange, trying to make sure that it's not just a silos, many silos across providers and otherwise. No, we have an ecosystem that works at the national level, whether it's the US, Europe, otherwise, et cetera. And there are really three success factors that we then need to look at. What's the data scope that we're collectively moving forward? Because trying to address everything all at once is not going to work. We need to roadmap that. Second is that we need to agree on the standards that everybody is going to use to exchange the data as a minimum bar. And third, we need to do that at scale with zero friction, and that requires some work as well. So taking the US as an example, the data roadmap is set by US Core Data for Interoperability, or USCDI. And that aims to define that initial set or that ongoing set that expands on what we need standards for. Over time, that is fully expected to cover all of the data that's captured electronically, because in the end, for a patient, we need to be able to exchange everything. And these kind of efforts are happening in other countries as well. In Australia, the CDI is being defined there as well. So what is really the data that we need to focus on? That second part is around interoperability standards. What are we going to use for the different messages that we need to exchange, documents that we need to exchange, e-prescribing that we need to do, et cetera, et cetera. So there is a lot of work going on there, and making sure that everybody uses a consistent vocabulary, so I can understand that. 807 Fire has emerged as a key standard being able to move forward, and we'll see more and more of that, so that the variety of very targeted mobile app kind of queries, large data set exchanges, interactive workflows across organizations, we can all do that in a very consistent format. So a lot of work going on to make that happen. And then the third factor is to scale without friction. And that's where you see in many countries different varieties of trusted exchange frameworks. So what is the governance? What are the infrastructure that we need to do that, so that we can get away from some of the point-to-point data agreements, that we all do that consistently. So in the US, that means TEFCA, or Trusted Exchange Framework and Common Agreement. That's what we're using there to move that forward, which is in turn building nicely on the work that Commonwealth has already done as a network. And Commonwealth was first co-founded by Cerner and now Oracle to address one of the key questions: where's the patient's data, wherever they have been across the country? So that those experiences are being taken into TEFCA, as well as care quality that focused on governance, common agreements, other elements that need to be in place. And you see that kind of an effort to create a common, consistent trust framework as a key building block to make it work at a national level. In the US, we now have 7 QHINs, Qualified Health Information Networks, that are forming the backbone of that. Commonwealth is part of that, and a couple more coming. So that's really what we're seeing emerge in a variety of different ways across the globe as well, on how we can tie it together. So that's the focus: national level exchange, standards based on a large data set that we can really follow the patient.
Hans, that's a fantastic story and really interesting to see kind of the snowballing of all of the historical work that started in the 80s, worked through standards at the departmental and hospital level, to the inter-organizational level, to the national level, to the international level, and how it always builds on what was there before. And so, just thank you for all the service you put into the industry and how we've built on the work of you and colleagues like you in this industry. I have a chance to participate on the Commonwealth board, as well as in the TEFCA governance in the transitionary council as a representative of Commonwealth. And it's really exciting to see how TEFCA is moving the meter in a lot of ways, and kind of taking what has been done and building upon it. And one of the more exciting features of TEFCA is not only kind of expanding the reach of the number of endpoints that are participating in data exchange, but also expanding the purposes for which the data can be used with kind of non-traditional partners. So instead of just focusing on provider-to-provider exchange, expanding and mandating, for example, an individual access to their data, or looking at healthcare operations and payment as kind of first-class use cases within the exchange. And Siva, speaking of the new use cases that are being demanded of interoperability, I understand that your team is looking at quite a few interoperability challenges that go beyond treatment. Can you help the audience understand why those non-treatment purposes of use are so challenging, what problems we're seeing out there, and maybe some solutions that are emerging?
Thanks, Sam. Good morning, afternoon, and evening, everyone. Thrilled to be here today to discuss this topic with you. Healthcare ecosystem has several entities that need to interact with each other. This could be the providers, the insurance payers, the pharmacies, public health reporting, who all need to come together to provide a high quality care to patients. Initiatives like Commonwealth are examples of successful collaborations that have advanced interoperability between providers and clinicians. But when you look at the depth of this problem, there are other entities that are involved in the care setting, and the same type of standards and scale hasn't been established. Providers need to interact with payers to determine a patient eligibility, for example. And today, for that, they have a lot of manual work involved. There's a study which indicates that about 1.5 billion phone calls and faxes are made from to the insurance payer companies from the providers to verify coverage itself. And when you think about the claim processing, when payers need clinical documents, about 26% of that documentation is currently only about that is being sent electronically to payers. And when you think about the providers who need estimates of their procedures, today it's a complex set of manual interactions between providers and the insurance companies, and each of them costs about $14 per estimate. Altogether, there's a detailed study that indicates that about 28% of the US healthcare administrative costs is due to these ineffective processes and collaboration between organizations. So while the standards have evolved, while we have an engaged process through Commonwealth and Care Quality and national networks that provide this type of an exchange between clinicians, we still have a lot of problems to solve. The lack of interoperability creates a significant burden. Administrative staff spend a lot of time reconciling data from different sources, leading to this increased costs. There's a huge opportunity ahead of us to streamline these operations, and we are trying to do that exactly as we speak. And we are currently solving a key problem related to exchanging clinical data between payers and providers. We are continuing to solve several other problems related to how we simplify the claims processing. Again, at Oracle Health Interoperability, we are dedicated to bringing our diverse backgrounds to deliver the most effective solutions for the various entities in the ecosystem. There's a lot of creative work going on currently on how to leverage technology to meet these challenges head on, all while maintaining the highest standards of security, patient safety, and efficiency.
Yeah, thanks, Siva. That was a great answer. And it's so interesting to hear about these problems of creating a true ecosystem that's not just centered around those providing care, but anyone really involved in the process of delivering care or receiving care. And that innovation you just spoke of, I did want to spend some time and really queue up this demo. But one thing I'm really excited about is to share with the audience in a little bit more detail the work that Oracle Health has been doing to improve the usability of the information coming from these data sharing networks like Commonwealth. Can you help us understand why usability is such a big issue and what Oracle Health has been doing to address that specific challenge?
A fantastic problem to go after, Sam. We talked about the huge amount of data that is going to come to the providers when we start connecting all these different systems. I'm going to invite Margo Jackson, who is our product manager working on the Seamless platform, to give us a lot of context about this problem and go over the demo of our product. Over to you, Margo.
Thank you, Siva. And thank you all that have joined the webcast with us today. For the next couple minutes that I have with you, I'd like to do a couple things. One is I'd like to provide a short demo of our Oracle Seamless Exchange product. But before I do that, I also want to be able to share with you some visuals. The visuals showing really some of the successes we've made around interoperability, but also I want to present the why we're not done. What are the challenges in front of us, and what do we need to solve around interoperability? We know that clinicians want to provide the highest standard of care for their patients. We sometimes hear them refer to it as like their desire or passion. We also know that people seeking treatment have become savvier and use the vast amount of information that's available to them to be selective in where they receive their care. So whether that information is coming from the internet or from family and friends. Together, this means we need to build open and strong bridges for sharing of patient data. At a national level, we have already provided some of that bridging through Commonwealth and Care Quality with the sharing of documents. With the advancement of TEFCA, QHINs, and other public health and registry reporting, patient data sharing is going to continue to increase, really allowing us the access to a clinically rich set of information on the patient. But with open data sharing comes the need to also ensure we are addressing usability concerns and not inundating the medical teams that are already overburdened. While we have been advancing our EHR as part of regulations, reporting, and payer needs, we do see this as impacting our users. With Seamless, we knew we had to address usability issues heads on. So while we took advantage of making sure that we were having all expanded access to where those clinical records are available, having more data through the discrete data concepts of like vitals and labs, so expanding on our capabilities well beyond regulations. We also knew, again, addressing usability concerns. So standing up a strong cloud capabilities of filtering and deduplication of that noise. Everywhere a patient goes, they're going to document what their medications are or what their problems and allergies are. And so there's a vast amount of information that is just repetitive being shared through the networks. So we need to have a strong filtering and deduplication capability. We also support with Seamless the ability to do trusted data sources, allowing if you know you have a care setting where you trust the data because it just happens to be the same users that are there. It might be the same cardiologist that's also servicing in terms of surgical care within your organization. We want that data to flow naturally into the EHR. So we built out this capability called trusted data sources. And lastly, we did intuitive workflows. So we took the clinicians from the space of where we used to have them go into understanding interoperability and how to access the patient data, to bringing that into more of an intuitive workflow where they just naturally treat patient and do documentation. With real-world experiences around free text and the documentation that's flowing through our systems, we do know that there's a lot of variances in how that data, whether it's drugs or drug allergy, is being expressed in the shared information. So we also are working on a release now around Seamless Exchange and AI capabilities, really allowing even better deduplication while still ensuring codified free text information is able to flow into our system. At this time, I'd like to transition us over to an actual demo of Seamless Exchange. For our Seamless Exchange demo that we're about to do here, I've selected a couple examples of different clinical data types that we would normally have to manage in terms of an assessment of a patient. This is done whether it's in an outpatient care setting or even in terms of inpatient, of course. During the demonstration, I'll show you our new intuitive workflows that we've released with Seamless and how we integrate that outside data natively as part of the end user documentation. We're going to start here with medications. We have Sophia Flores, who's a 37-year-old female. She's a surgical patient. This happens to be an inpatient visit that she's having for some more surgery. When we take a look at medications, we want to make sure we have a complete list of all the medications that she may be on. So here we see that we've already got charted 3 medications on her, but we also know there's other medications outside. So we can be able to view these outside records. This is a preference setting. We'll go ahead and set that to 6 months. If your setting is too far back in terms of pulling in home medications, you are going to bring in a lot of historical information. You can always set your filters and change your filters, and we can be able to see all medications, and users can be able to manage to that. We're going to go ahead and set this back to only the 6 months. When we're looking at this information, we're provided both the view of what's outside data on the left-hand side, and we also have in the local record what's on the right-hand side. So we're able to seamlessly compare the information as far as what's flowing in from the outside data. By the time the user is actually viewing this information, we've already done that heavy lifting of going out across the networking, pulling back all the records on the patient and parsing if needed, going through that whole comparison duplication, as well as filtering information, so that when they are looking at this information, it's a reduced list of only some information that's new for the patient. During this review of the patient, we can go ahead and we can be able to reject information. So if we know the patient's never been on oxycodone, we want to be able to go ahead and reject that. At any time, users are able to go ahead and change the status here, and they can actually see information that's previously rejected, and they can undo that if they want. Let's go ahead and navigate back to our pending work list of things to review. We have the ability in here to be able to see provenance information. So whenever we bring information in from outside sources, we always make sure that we tag it as far as it wasn't from our location, our particular care setting. So we want to reflect where did that data come from. So we do have a provenance record, we call it. It has what the originating source. So we see here, in this particular case, Sophia was actually at another surgical center. She was at Banner Surgery Center. We have documentation from that care, and we can be able to launch into there. And this is where we're able to see that that particular medication on the patient had been documented. Users can go ahead and scroll through here and see context of information that occurred at that other location. We're going to go ahead and close this down. And users have the ability at this point in time, if they want to, in terms of adding that information into the patient chart. In this particular case, we can see that there's some information that is still missing on the patient, and we can be able to fill in whatever those details are that are required. Let me go ahead and close this out. When we're done with our review, we have the ability to do reject remaining. So with provenance across all our clinical concepts of outside data that we're bringing into Seamless, we always show that ability to show that outside provenance. We also have bulk actions in terms of rejecting remaining, and there's a commonality across all the clinical data that we're bringing from outside sources into our system and our workflows. We have this concept of add or reject for anything that is subjective data that has to be reviewed. When we're done with our review of medications, we also provide for our users a very convenient way to be able to mark as reviewed. And this gives them credit in terms of having conducted the home medications collection on a patient. Let me go ahead and close out of here. And we're going to go ahead and navigate to a different patient. We're going to go to Suzanne Gill. So Suzanne Gill is a 57-year-old female. She is presenting for an outpatient clinic visit that she wants to do. We're going to go ahead and take a look at Suzanne's allergies. So as a clinician, we're in Millennium System. I would normally navigate up and through that workflow in terms of collecting the relevant information needed as part of the patient care. So here we see with allergies, she already has 2 allergies documented. We have amoxicillin and we also have ibuprofen. And here we also see that there's outside records available. So we can go ahead and view those records. When we're reviewing the records, just like with medications, I have ability to see provenance information. So when we click on the shellfish, we see the provenance information that this record came from Rock Creek Clinic. We also keep the capability with Seamless Exchange of what we call related outside provenance information. So if shellfish has been documented at a different care setting, and other documentation has been retrieved on that patient from that care setting, we're able to view that information in the document as well. So once again, users can navigate and take a look at the information. If they want to take a look at health concerns or even clinical notes on the patient, they could be able to navigate and review in context that additional information. Let me go ahead and close this down. Much like with medications, we can go ahead and reject. So if we know for a fact that the patient doesn't have shellfish, we've had that conversation with them. We want to be able to reject it so that it never comes back in, that we have that addressing really that echoing that occurs where we can't correct the source system all the time in terms of the accuracy of their record, but this allows us to manage to making sure that we're removing that noise of interoperability data. So we'll go ahead and show you with reject. Again, much like with medications, we have different filtering available. We have date range filtering, and we also have status filtering. So here we can go ahead and review shellfish, reject. And if at the end, we actually just find that this patient has a shellfish allergy, we can go ahead and undo that as well. So let me go ahead and go back to our pending allergies on this patient. When we're going to add an allergy like shellfish, when we go to add that information in, as with medications, if there happens to be any missing information that didn't come across with our interoperability data, we're able to select and supplement that information and fill that in so that we can go ahead and save this into the record. In the case of where we're getting free text information, we also have the ability to look up within our own catalog through that text search most likely candidate in terms of what the allergy is. So in this case, we're able to select tree nut, and that moves that from being a free text to actually a codified allergy. And then we fill in whatever else is required. The definition of what's required in terms of these red star items is really within each of the EHR systems. Within each one of our Millennium clients, they can define what their minimum requirements are as far as outside data flowing into their system. Let me go ahead and close this off. And much like with medications, we have bulk capabilities where we can do reject remaining. So after we've gone through, assess the information as far as what allergies the patient has, we can go ahead and reject the remaining information. And as with medications also, we have mark as reviewed. So with allergies, you can go ahead and mark the patient review as having been conducted. Let me go ahead and close out of here. And at this time, I'm going to go ahead and turn this back over to Sam. So thank you for your time today.
Margo, thank you so much for showing such a delightful demo of Seamless Exchange. Your team's been at hard work, and it shows in the work that you've put forward today. And thank you again to Siva and Hans for the panel discussion. It was very well thought out, and we've enjoyed your contributions. Now, Shanna, I'm going to hand it back to you to close. Thank you.
Well, thank you so much, Sam. It's always a pleasure to connect with you. And thank you to you and your team for those updates, perspective, and the demonstration. I am so excited to learn more at the Oracle Health Summit. And speaking of the Oracle Health Summit, that's going to happen in a couple months, and it's going to be in Nashville on October 29th and 30th. That's going to provide our customers the opportunity to learn more about Oracle Health and life sciences, product advancements, and so much more. Tune into our website to know all the detail that's going to happen during that time and during that event. And I can't wait to connect live with each of you. On behalf of all of our speakers today, thank you so much for joining us again for another Oracle Health Inside Access, and have a great day.